Good afternoon, madam.
I hope you can see my screen now.
Yeah, madam.
Okay, thank you. I'm Dr. Lanedi Silva. Lecture is on joint infections. So, the learning out. Third objective, discuss the reasons for the development of chronic osteomyelitis. Describe the complication of chronic osteomyelitis. Then as the fifth objective, you have to describe the pathogenesis and complications of tuberculous osteomyelitis. And at the last part, I'll be doing the pathogenesis and complications of septic arthritis. So this lecture is having two parts. First is on bone infection, that is called other osteomyelitis. Shortly I'll be discussing, and then I'll be doing joint infections. I have seen someone has raised her hand. Who is that? Maheshika? Okay. So under osteomyelitis, it is the inflammation of bone and bone marrow cavity. It's not only the bone, it includes the bone marrow cavity inflammation as well. It is almost always implies an infection, because you know that inflammation could be due to some other reasons as well. But when we are talking about osteomyelitis, it is almost always due to infection. Out of these infective agents, bacteria is the causative agent in most of the time. In addition, sometimes we can get virus-induced or fungal or parasitic-induced osteomyelitis, but these are very, very rare. But we can classify osteomyelitis in different ways. One is based on duration. It could be acute, subacute, or chronic. If the osteomyelitis is short duration, we are calling it as acute osteomyelitis. If it has gone for some time, it is subacute osteomyelitis. And if it lasts for prolonged period, then it is chronic osteomyelitis. And we can classify it again according to the route of infection. Route of infection could be hematogenous or non-hematogenous. Then we will call it as exogenous. And again, we can classify osteomyelitis based on host response. It could be pathogenic or granulomatous. First, we will look at the etiological agents of acute pyogenic osteomyelitis. The most common cause is Staphylococcus aureus infection. In 80 to 90% of the cases where we identify the causative agents, the causative agent is Staphylococcus aureus, because in this bacteria has a surface protein that allows it adherence to bone matrix. So it has an affinity to have bone infection. In addition to Staphylococcus aureus, we might get E. coli, Klebsiella, and Pseudomonas, especially osteomyelitis associated with genitourinary infection or osteomyelitis in IV drug users. In neonates, the causative agents is different. Most of the time, they get osteomyelitis due to H. influenzae or group B streptococci. And the patients who are having sickle cell anemia mostly are having commonly salmonella induced pyogenic osteomyelitis. And if it is after bone trauma, most of the time the infection is mixed. because it's due to contamination with the surrounding organisms. So usually we get mixed type of infection in osteomyelitis when after bone trauma. So there are some risk group who are getting acute osteomyelitis. One thing is very young and very old people like neonates and elderly. Sometimes immunocompromised patients, because immunocompromised patients are more prone to get any type of infection. And the patients who are having open fractures, so they are exposing their bone into outside environment. So they are also having high risk of developing acute osteomyelitis. And the people who undergo surgical procedures, especially for prosthesis, are having a high risk of developing acute osteomyelitis. And IV drug users, also the patients who are having peripheral vascular disease or diabetes are having a higher risk of having acute osteomyelitis. So then we will talk about route of infections. The main or commonest route of acute osteomyelitis infective route is hematogenous. That means the infection, the infective organism from a distant primary focus is traversing through blood into the bone. So the distant primary focus could be skin, could be middle ear infection, genitourinary infection, or the people who are using IV drugs can get these kind of hematogenous spread, and uncommonly can get direct implantation, especially after a compound fracture or after a bone surgery. Also, it could be spread from the adjacent organ, like a person who is having infected dental caries, forming an abscess. These organisms can spread into the adjacent bone in the jaw, causing osteomyelitis of the jawbone. And people who are having diabetic foot ulcers can commonly get acute osteomyelitis in adjacent bone. So those are the routes of infections in acute osteomyelitis. So these pictures explain how these organisms enter into the bone. The main route is hematogenous, and it could be spread from surrounding soft tissue, or it may directly implanted over the bone after a surgery or a trauma. And something important you have to remember is that most of the time the osteomyelitis is at the metaphysis of the bone, if that is of a long bone. There are many reasons for that. The main reason is, if you can remember the blood supply of long bone, it entered at the metaphysis, and at the growth plate, these arteries bend like a hairpin into the venous system. It won't go beyond the growth plate into the epiphysis. So these terminal branches of metaphyseal arteries form a hairpin loops at the growth plate. So blood flow at this site is sluggish and turbulent. This sluggish and turbulent flow facilitates bacteria seeding at this point. And in addition to this course, there is some changes in the endothelial function of these the capillaries, promoting bacterial seeding at this point. So ultimately, what you have to remember is that osteomyelitis is more common at the metaphysis of the bone. And there's a difference between the sites of infection according to the age. In infants, where the growth plate is open, metaphyseal arteries is having a connection between the growth plate into the epiphysis. So whatever the infection that is coming into the metaphyseal region will enter through the growth plate into the epiphysis. So these infants, usually less than 2 years of age, children less than 2 years of age, if they get osteomyelitis, usually it involves a metaphysis plus or minus epiphysis. But in all the children who are more than 2 years of age, the infection confined to the metaphysis. It won't go into the epiphysis through the growth plate because the metaphyseal arteries won't have connection through the growth plate into the epiphysis. And epiphysis is having a separate blood supply. It won't connect with the metaphyseal arteries. So whatever the infection that is coming into the metaphysis will remain there and it won't go into the epiphysis and the joint space. But again, when we consider the adults, they don't have the growth plate and they have connected with the epiphyseal arteries, and there's a connection between metaphysis and the epiphysis. So infection coming into the metaphyseal area will enter into the epiphysis. So in adults, if it involves a long bone, it involves a metaphysis plus or minus epiphysis. In addition, they can get infection in the spine vertebrae also. Is it clear to you?
Yes, madam.
Okay. When we consider the clinical features of osteomyelitis, you know that it is acute inflammation. So all the features that you have learned in your foundation module on acute inflammations are there. Localized symptoms, the features like pain, redness, swelling, warmth, and limitation of movement is to be there. In addition, systemic features like high fever with chills, loss of appetite, malaise is to be there. And if you check the blood levels, those changes, the acute inflammatory changes could be there. But sometimes in infants and children, the presentation may be atypical. That means they won't complain about the pains and redness and swelling, and most of the time child will come with fever and not moving the limb like usual days, and poor feeding in neonates. Those are the symptoms. Those are very non-specific, kind of an atypical presentation in infants and children. So if we do the investigations, the full blood count, as it is a kind of acute inflammation, you can see neutrophil leukocytosis. That means high WBC count and high neutrophil count. And the other inflammatory markers like CRP will be elevated, and you will get high ESR level as well. And if you culture the blood or tissue, bone tissue, you can get bacterial culture, but this is not always true, because if the patient has been treated with empirical antibiotic, you won't get positive cultures. And if you do an X-ray, you can get a lytic lesion surrounded by sclerosis. I will show you why it is there. And in MRI or bone scan also, you can get features of inflammation and lytic lesion in the bone. And the usual, I'm not going to talk about the management of blood because this is a pathology lecture. So management, basically, it is the IV antibiotic followed by it has to be for a long period, followed by oral antibiotic. Remove the sequestrum. I will tell you what is called sequestrum is. Those are dead bone particles. We have to remove those dead bone particles with the wound depth remove to facilitate healing. Now we are coming into the important part of this lecture, the pathological processes involving with acute osteomyelitis. Here I have listed out number of basic pathological processes that is involved with acute osteomyelitis, but these depend on the stage of the disease and the location of infection. Basically, if you describe acute osteomyelitis, you have to think about acute inflammation, suppuration, necrosis, new bone formation, and healing by regeneration of bone. Those are the pathological processes involved with acute osteomyelitis. And as I said earlier, the infection can come through blood or through local spread or due to implantation, direct implantation. Whatever the root of the infection, the causative bacteria will enter into the bone. Once it is entered into the bone, it will proliferate within the bone, especially within the bone marrow cavities near the metaphyseal region. And it will cause acute inflammatory reaction and suppurative necrosis of the bone. And because of this acute inflammation, edema, and suppurative necrosis, the intraosseous pressure will go up, especially due to inflammatory edema. And also, this inflammatory edema will obstruct the blood flow, causing further damage to the bone, and there should be ischemic necrosis of the bone. And because of this high intraosseous pressure, patient will develop intense pain. So these are the mechanisms of bone necrosis in acute osteomyelitis. First thing, if the inflammatory edema is marked, this causes obstruction of the blood flow, resulting in an element of ischemic necrosis because due to edema, it will obstruct the blood flow into the bone, causing ischemia. In addition, these pus-forming organisms and also acute inflammatory mediators may lead to suppuration and necrosis of the bone, dissolution of the bone within that area. Those are the two main mechanisms of necrosis in acute osteomyelitis. In addition, supportive processes like blood stasis, thrombosis of the surrounding vessels, and periosteal stripping. I will explain what is periosteal stripping later. Also, because you know that the blood supply of the bone is coming from the periosteum to the bone matrix. So if the periosteum stripped off from the bone, then the blood supply will be obstructed and causing ischemic necrosis. There are many reasons for necrosis in acute osteomyelitis. Remember few of the causes. So again, continuing the pathological processes. So by the second day of the disease, due to this necrosis and acute inflammatory process, there should be suppuration of that area. That means pus necrosis and pus formation. The pus will appear at the medulla, forming intrametaphyseal abscesses. And once it is formed the abscess, the bacteria travel through the Hawaiian system to reach the periosteum. There's a difference in pathological process in children and adults because, as explained in this picture, when the pus within the bone enter into the Hawaiian system and the periosteum, in children, the periosteum will strip off from the bone, forming a subperiosteal abscess. Because the periosteum is loosely attached to the underlying bone in children, so it can easily strip off. And the pus will extend along the bone surface, clipping up the periosteum, forming a periosteal abscess. This will happen only in children. But in adults, the periosteum is firmly adhered to the bone. It won't strip off from the bone surface, so pus won't tract beneath the periosteum, making periosteal abscess in adult. Instead, it will make a kind of an abscess, but when the pressure goes up, abscess will rupture and the pus will come out from the bone into the surrounding soft tissue, or maybe through the skin, forming a sinus tract. So there's a difference in pathogenetic mechanism in children and adults. So due to rising intraosseous pressure or vascular stasis, infective thrombosis, and periosteal stripping, the blood supply will further compromise into the bone. So you will get necrosis during the first week of period of acute osteomyelitis. This necrotic bone within the infected site is called sequestrum. Remember that term. The sequestrum is called the necrotic bone. And pieces of this necrotic bone may pass through the sinus and discharge out from the bone into the skin surface sometimes. This bone particle, dead bone particle, can be there at the wound debridement site. And in addition, there's another process happening where there's a new bone formation surrounding this necrotic area. New bone forms from the deeper layers of the periosteum. You know that from the bone healing lectures, normal bone start to form from the periosteum. When there's a fracture also, the same thing will happen. So when there's a bone formation from the deeper layers of the periosteum, it will later surround this necrotic bone. So this new shell of bone around this necrotic bone is called involucrum. So another new terminology. So a shell of new bone around this dead bone is called involucrum. These two terms are there in acute myelitis, acute osteomyelitis. So you have to remember those two terminologies. So the organisms can persist maybe for years after the initial infection within this necrotic core because it is surrounded by a shell of new bone. So this is a picture of acute osteomyelitis with the diagram to explain what is called involucrum and what is called sequestrum. So you know the necrotic center, necrotic bone center is called sequestrum, which is there in this macroscopic photograph as well. And the bone shell surrounding this necrotic center, which is formed from the periosteal surface, is called involucrum. So, healing of inflamed bone, if the infection is controlled either by antibiotic or surgery or by both, and the intraosseous pressure is released, and bone will undergo healing, and you can get the normal bone later if healing was rapid and the bone damage is minimum. Sometimes it can spread, it can progress into chronic osteomyelitis. So what are the reasons for progression into chronic osteomyelitis? If there's a delay in diagnosis of osteomyelitis. So if it is delayed, we will be treating late. So there will be a huge damage to the bone, underlying bone, which make the healing is impossible, progressing into chronic osteomyelitis. If the necrosis is very extensive, then again acute osteomyelitis will progress into chronic osteomyelitis. And if the antibiotic treatment or surgical debridement is inadequate, then again it will progress into chronic osteomyelitis. And the patients who are immunocompromised are also having high risk of progressing into chronic osteomyelitis. Then we'll talk about the complication of osteomyelitis both together, acute osteomyelitis and chronic osteomyelitis. In acute osteomyelitis, main complication is progression into chronic osteomyelitis. That is smoldering continuing infection with bone over months or years. And other complications are development of acute flare-up of osteomyelitis. That is due to the surviving bacteria within this necrotic center after involucrum is formed. And these patients can get frequent pathological fractures, and you know it's a common cause for acute secondary amyloidosis, because you must have heard that amyloid cause chronic osteomyelitis is a cause for secondary amyloidosis, and these patients can develop infective endocarditis, sepsis, and sometimes with the chronic osteomyelitis, chronic wound, can lead to squamous cell carcinoma in the sinus tract, and very rarely, very rarely, they can develop osteosarcoma as well. But if someone asks about the complication of acute or chronic osteomyelitis, don't tell osteosarcoma as the first cause, because it's a very rare thing. Just to mention that there's a possibility of developing osteosarcoma in chronic osteomyelitis. So I have one true or false type MCQs. So first one, the commonest organism causing osteomyelitis is Streptococcus pyogenes. Is it true or false? Who is going to answer?
Streptococcus aureus.
Yeah, that is false. Second one, infection by mixed organisms is characteristic of sickle cell disease.
False.
It is false. In sickle cell patients usually get salmonella-induced osteomyelitis. Bone necrosis is due to raised intraosseous pressure. What do you think?
It can be true because raised intraosseous pressure
Yeah.
can lead to ischemic necrosis.
Yes, it is true. The necrosed bone is infected site is called involucrum. Is it true?
False. It is the rim of the newborn.
Yes. Squamous cell carcinoma of sinus tract is a complication of chronic osteomyelitis.
True.
It is true. Though it is uncommon, it is a possible complication. Okay. So, again, an important question. In infants, infection often extends to epiphysis and then to the joint space. Can someone tell why it is? What's the reason for that? I explained that one.
Because the metaphyseal arteries have access to epiphysis.
Yes. Okay, so vessel penetrate the growth plate from the metaphysis into the epiphysis. Second one, in all the children, the joint space involvement is rare. Why is that? Who is going to answer?
There is no connection between epiphysis and the metaphysis. There is a separate supply to epiphysis.
Yeah, growth plate acts as a barrier to the direct spread, and the epiphyseal blood supply is separate from the metaphyseal blood supply. But there's a possibility of getting joint space involvement, because if you can remember the anatomy of some of the joints like hip, shoulder, and elbow, you can remember that the joint capsule partly surround the metaphysis. So joint capsule extend up to the metaphysis. So in those cases, the metaphyseal infection can directly enter into the joint space. So it is not always always wrong, because older children can get joint space involvement, especially in hip, shoulder, and elbow. Next one is in adult, infection may involve the joint space. Why? I will give the answer. Because in adult, there's a re-establishment of communication between the metaphysis and the epiphysis. So with that, we have finished the acute and chronic osteomyelitis. We can move into the tuberculous osteomyelitis. As the tuberculosis infection in elsewhere in the body, it is caused by Mycobacterium tuberculosis, and it's commonly affect lower thoracic and lumbar region of the vertebral column. So the vertebral column tuberculous infection is called Fort's disease. That's the term that we are using. And other than the spine, this infection can get inside, especially knees and hips. This is due to part, as if you can remember, the pathogenesis of tuberculosis. This is due to reactivation of dormant bacilli that was entered before the immune response is established, especially in childhood. And if the patient is immunocompromised, they can always get disseminated TB and also reactivation of dormant bacilli, which are there from the childhood. And sometimes this may be due to contiguous spread from the lung, because the commonest site of tuberculous infection is lung. From lung, it can extend into the surrounding bone, like to the sternum ribs. So maybe sometimes it may enter from the lymphatics into the adjacent bone. So compared to the pyogenic osteomyelitis, TB osteomyelitis is more destructive and it is more resistant to control. It's a type of chronic osteomyelitis. So with hematogenous spread, the long bone and vertebrae are the favorite sites, and lesions usually solitary. But if the patient is immunocompromised, these patients can get multicentric disease. And one important thing to remember is synovium of the joint is the common site of initial infection, because tuberculous bacillus is microaerophilic bacillus. So that means it likes oxygen. So synovium has the highest oxygen pressure compared to the adjacent bone. So most of the time, the synovial infection is the primary site of infection at the bone. And the infection can spread and form a typical granulomatous infection. I don't want to describe the granuloma and the caseous necrosis. Those have been done earlier. You know those very well. And because of this granulomatous infection and the caseous necrosis, bone will undergo extensive destruction. So if we talk about what are the complications of vertebral bone tuberculosis or Port's disease, when there's a vertebral bone necrosis, it will extend into the intervertebral disc through the bone and into the adjacent vertebrae. So when there's a destruction of the vertebral bodies and the intervertebral disc, there's the possibility of compression fracture of the vertebral bodies, ultimately leading to kyphoscoliosis and compression over the spinal cord and the nerve roots, causing neurological deficits. In addition, this caseous material can track through the psoas fascia into the ileal region, making the ileal psoas abscess. And one important thing to remember is that in tuberculous osteomyelitis, there's very little bone formation, but extensive necrosis and fibrosis. Infection in one vertebral body, it may extend into the adjacent intervertebral disc and the adjacent bone, causing destruction of the vertebral bodies and kyphoscoliosis. And this is an MRI of a patient who had this Potts disease. You can see the appearance of vertebral body compared to the adjacent normal vertebral body. These have been disrupted. And look at the curvature of the lumbar vertebra, sorry, thoracic vertebra, here causing kyphoscoliosis. So complications, as I said earlier, the main complication is kyphosis or scoliosis and spinal cord or nerve compression, and patient can get paraspinal psoas abscess and sinus formation, and this is a chronic osteomyelitis, who can get amyloidosis, and this can spread into the joints, adjacent joints, causing tuberculous arthritis. Maybe not in the spine, in other bone sites, you can get tuberculous arthritis as well. So far we have covered the pyogenic osteomyelitis and tuberculous osteomyelitis. Now we have to talk about other type of bone infections. The main type of bone infection is syphilis and yaws. Syphilis is by Treponema pallidens and yaws by Treponema peritoneum. It could be either congenital or acquired. Congenital syphilis is caused osteochondritis or perichondritis of the bone. Early in fetal life, maybe in the 5th month of the life, they can develop these lesions. And in acquired syphilis, mainly involves the facial bone, involve nose, palate, and skull. Or maybe really long bones. I don't think that you have to know much details about the other bone infections. So with that, we can move into the infective arthritis. So arthritis, by terminology, you know it's the inflammation of the joints. There are many different etiologies for this. Osteoarthritis, rheumatoid arthritis, infective arthritis, immune reactions, and crystal-induced arthritis. But here I'm going to talk about only on the infective arthritis. You will be getting a separate lecture on osteoarthritis and rheumatoid arthritis. And if you don't have any exposure to the immune-mediated arthritis or crystal-induced arthritis, please read it in your book only 1 or 2 pages in the province. So if you talk about the infective arthritis, the most common thing is the suppurative type or pyogenic arthritis. In addition, you can get infective arthritis due to mycobacterial infection, viral etiologies, mainly due to alpha virus, PAU-B90, rubella, EBV, hepatitis B or hepatitis C viruses can induce infective arthritis. And sometimes Lyme disease, though it is not common in Asian countries, it is there in European countries, USA. So you have to know a little bit about Lyme disease, that is due to Borrelia burgdorferi. So I'm not going to talk about this Lyme disease in this lecture because it's mainly focusing on suppurative arthritis. But if you are interested, you can read just to know a little bit about Lyme disease, because it is considered as a disease due to infective organism as well as a disease due to immune reaction. So we will talk about the septic arthritis. It is an infection in the joint. So you know, arthritis is the inflammation of the joint. Septic means when it is involved by the pyogenic infection. So the usual etiological agents are the bacteria. So under septic arthritis, we have to know what are the routes of infections and what are the risk factors for septic arthritis and what are the clinical features you are expected to see. So first we'll talk about the route of infection. This is something similar to the route of infection of acute osteomyelitis. So here also we are talking the same thing. It could be hematogenous through bloodstream. It may be due to local spread from the bone infection, or maybe directly involved in the joint, or sometimes maybe due to implantation, because maybe after a trauma into the joint, or sometimes after iatrogenic causes like intra-articular injections, because the patients who are having arthritis due to other reasons, maybe due to osteoarthritis, maybe getting steroid injection directly into the joint. So these people are in high risk of getting infection due to bacteria. So there are many risk factors, as we discussed under acute osteomyelitis. There are many risk factors involving the acute septic arthritis as well. If the infection is due, if the infection comes from blood, there are a separate set of risk factors like immunocompromised patients, especially the patients who have complement deficiencies. If the complement deficiency is involving the membrane attack complexes, that means complement factor 5 to 9, those patients are more prone to get blood-borne arthritis, and other causes of immunocompromise like diabetes, HIV, or immunosuppressive drugs may lead to blood-borne arthritis. And the patients who are having IV drug users and other systemic causes for sepsis also may lead to arthritis. And the patients who are having disease in the joint, like osteoarthritis, rheumatoid arthritis, or the patients who are having prosthetic joint, are in a high risk of developing arthritis. And for gonococcal arthritis, the sexual activities are risk factors. The infections due to local spread may be due to skin infections or ulcers, and risk factors for direct inoculations, as I said earlier, intra-articular injections, joint surgeries, or the joints with prostheses are at a higher risk, and invariably people who are old age are having a high risk of getting arthritis. And clinical features, this is we are talking about acute inflammation of the joints. So those are the signs of inflammation, like redness, swelling, pain, heat, or loss of functions, like systemic signs of inflammation like fever, malaise, raised WBC count, high ESR, CRP, those things. And usually it affects large joints, single large joints, and sometimes it can involve multiple joints as well. And hip joint is a commonest site of inflammation in children who are less than 3 years of age, and in children who are older mostly get knee joint infection. Etiological agents, like in acute osteomyelitis, the etiological agents are different in different clinical settings. Children who are under 2 years of age mostly get H. influenza-induced arthritis, and older children and adults mainly Staphylococcus aureus. And sexually active women will get gonococcal arthritis, and like osteomyelitis, here also the people who are having sickle cell disease can get salmonella-induced arthritis. And this is the pathogenesis and the complication of septic arthritis. The infection can come through blood, local spread, or direct implantation, and bacteria will proliferate within the joint. And once it is proliferated, the infection may spread into the adjacent structures. One thing is pus may break through the joint, forming abscesses and sinuses in the adjacent soft tissue. And due to the infection itself, or maybe due to the acute inflammatory mediators released from the inflammatory cells, the articular cartilage covering the bone surface at the joint will get destroyed. And when the articular cartilage is destroyed, the healing will be delayed. When it is healing, The raw articular surface will form fibrous connection with the adjacent bone, the other side of the bone, forming fibrous ankylosis. That means usually we don't have a connection between two surfaces of the joint surfaces because those are covered with the cartilage. When the cartilage is damaged, there's fibrosis causing fibrous connection between the two articular surfaces. So joint won't behave as a joint thereafter because two joint surfaces are bound together by fibrous bands, and later this will be replaced by bone using bone ankylosis. Those are the main serious complication of acute septic arthritis. So complications: dislocation of the joint due to intense effusion and the pressure inside the joint space. Epiphyseal destruction due to direct spread of infection from the joint space into the bone. Growth disturbances if the infection go up to the growth plate, especially in children, the growth plate will get disrupted, causing growth disturbances. Ankylosing, maybe due to the bone ankylosis or fibrous ankylosis. So that's all I have to do on the bone and joint infection. Do you have any questions to ask? Did you understand what I was talking?
Yes, madam. Madam, can we have the lecture slides, madam?
Yeah, I will definitely upload into the LMS. Sorry, I couldn't put it because I had some connectivity issue in the morning. So I have prepared the PDF. I will put it into the LMS.
Okay, madam. Thank you.
Okay, if you don't have any questions, I will summarize the lecture again. We talk about acute osteomyelitis. Under that, acute pyogenic osteomyelitis, that is the inflammation of the bone and bone marrow. It is almost always due to bacteria. And the Staphylococcus aureus is the commonest organism. And etiology and the extent of infection depend on the clinical settings. We talk about the neonates, children, and adult settings. And there are many pathological processes involved in acute pyogenic osteomyelitis, including inflammation, suppuration, necrosis, new bone formation, healing by regeneration of bone. And we talk about two different terminologies, sequestrum and involucrum. You have to remember those two. And under chronic osteomyelitis, we talked about tuberculous osteomyelitis and Fort's disease, and it can lead to lethal complications due to spinal cord compression. And lastly, we talk about septic arthritis, that's the inflammation of the joints due to bacteria. So that's all I have to do. Thank you very much.
Thank you, madam.
Madam,
Yeah, yes.
in involucrum, it will prevent that means the abscess not totally removed. So do we need to remove the abscess? That means remove the pus?
Yeah, because this is because at the as a part of healing, if I can show you the picture earlier. Wait. Yeah, here. Here, if you can see in this picture, the middle part is the dead bone. Okay, it is dead, and so dead bone particles, that is called sequestrum, inflammatory cells, necrotic debris, and the pus will be accumulated within the center. So if the necrosis is, the extent of necrosis is small, this can be healed by bone formation. So won't be an issue if we treat them properly and quickly with the appropriate antibiotics and wound debris. There won't be any necrotic tissue inside, and it will heal properly. But if the damage is high, if the if a lot of bone has been damaged and the sequestrum, if the dead bone particles are large, those cannot be removed by our body itself. Okay, so the bone will, the new bone will form. This is a kind of a cross section of the, longitudinal section of the bone. So imagine three-dimensionally, the new bone will form from the periosteal surface surrounding this area, like an eggshell surrounding that area. So the purpose of forming this new bone is to limit the infection into this side and to facilitate the bone healing. So if we can treat the patient properly, this part will be removed, and the new bone will replace this damaged area. There won't be an issue. But if we can't remove this necrotic debris, and if we can't treat the patient properly, this necrotic debris will remain, and the viable bacteria will remain within this center, and it is covered with the bone. So whatever the immunological reaction won't happen properly inside this bone shell, so bacteria will remain there. Okay, is it clear now?
Okay, madam.
Do you have any more questions? If you don't have, we can wind off. Thank you.